Welcome everybody to another VITA Learning webinar. Today we have Mr. Peter Peasy. How are you doing, Peter?
I'm good, Jim. Good to see you and good to catch up with you a little bit before this.
Yeah, it's very nice to discuss the market, discuss all these different things that are coming through our market. Today, 2022. Unusual year, but we're starting out a lot with webinars and then hands-on programs, whether remote or not. So we look forward to seeing you in the field and actually doing some hands-on courses as well.
Looking forward to it.
So today this is actually a little bit different. We've got a lot of webinars that we've been doing with Peter over the last year, this year. We're getting a little bit back today in the essential, what I think, which is the basic shade in photography, something that we all would like to be better at. We all would like to be able to communicate shades better, and we would like to be able to just talk about shade in a more friendly manner between the laboratory and the clinic, just to make sure we get the right materials, the right photographs, the right shade, so we can reduce costly remakes, things of that nature. So this is an excellent topic, I believe. I know you deal with this every day, Peter.
Yeah, no, this is actually one of my favorite topics. I switched it around a little bit to be a little something different today, but at the same time, I think it's one of the most important things that we tend to move through a little too quickly.
Yes. So those of you that are attending today, all of your phones are on mute. So if you'd like to send us a question, we'll have a Q&A at the end of the program. Send us a question through that panel that pops out on the right-hand side of your screen through GoToWebinar. Just highlight the questions and then type in your question, send that along, and we will use those at the end of the program. So please send us your questions. We're always like it so that we have a lot of questions at the end. This workshop, this webinar will be recorded. So give us a couple, 2-3 days, but we will edit it slightly, just skinny it up, just slightly put some title stuff on it and things like that. We'll post it to our VITA North America YouTube channel. And then you can go back and visit today's webinar, as well as others that we did last year and previous ones to this year that Peter has done. So please join us at our. Go ahead.
You said you're going to skinny it up. If you don't mind, I'll take 5-10 pounds off that too. If you could do that while you're working.
Yeah, we air, kind of skinny out the face and remove my glasses. So we just any of the dead time, not that you have any dead time, but when I say skinny, we're not editing it into the sense that we're recreating it. We're just making it sure that it's tight, compact. All the stuff that I'm talking about right now probably could be deleted.
I thought you were going to put my Rob Lowe mask or something.
Oh, believe me, if you haven't visited your own videos online on the YouTube channel, we do all sorts of things to your face. So you should check it out. You're a whole new person.
Yeah.
All right, so shade in photography. Those of you who are not familiar with Peter, he is a worldwide dental educator for technicians, dentists, and auxiliaries. He speaks to clinicians one-on-one with other technicians, assistants. He is one for all for one type of a technician, master technician. He's the owner and manager of Peasy Dental Studio in Staten Island, New York. He has a personal appreciation, expertise of all phases of clinical, laboratory, traditional, digital techniques, which is great, a whole new era with digital dentistry, Peter, and I know how you've adapted to that well. And then color communication, of course, digital photography. He's a board member of the Association of Master Dental Technicians. He is an MDT. He's a teacher and educator in the Master Dental Technician program at New York University and also a faculty member at the NYU School of Dentistry. He's a member of the American Academy of Aesthetic Dentistry. He's an executive board member and fellow of the Northeastern Nathological Society. He's the editor-in-chief of Inside Dental Technology, and he is an ACP Technician of the Year 2018. So welcome, Peter, and we look forward to your exciting presentation today.
I appreciate it. If you want to hand over the screen, and
I will do that. You are now the presenter. We'll see you on the other side.
Sounds great. Thanks, Jim. Okay, well, welcome everybody back to another week, another month. Boy, the time is flying like crazy, and you could probably see my eyes that I was here till 11, 12 o'clock last night, and I'll probably do that again today. So a little crazy few weeks here of business. But as Jim said, things are changing. The world is opening up a little bit more than before, and I know I just booked some flights for the first time, which I'm really excited about. So I look forward to being in some different states and some different countries coming up as this year goes on. So really exciting times. This topic is kind of personal to me in the sense that I preach a lot about photography and communication all the time. I really feel like it's the one thing that we probably spend the least amount of time on, where it's really the most important thing that we do, because none of the things that we can achieve, understanding materials or treatment planning or any of the obstacles that we face, all come down to the information that we have, and the information is really the most critical part. So for me, most of you already know I'm from New York. This is my office where I am sitting right now. I'm actually in the little office in my room, trying to keep it as quiet as I can while everybody's working away. Jim also mentioned that I'm the editor-in-chief of Inside Dental Technology, which I'm also very proud of. I don't know if you guys got this month's issue yet. My editorial was on something called The Shiny New Object, which I hope you get a read through. And the bottom line is it was really just about trying to keep us focused on our tasks at hand and what we can do, rather than always just being distracted by the next and the best thing, or the shiny object that floats through the room, which I see happen to so many people. And next month, which I just finished up and sent in, is really, it's a give back issue. And I think it's kind of took a different twist on the give back concept, and talk about some of the sacrifices that we've made over the last few years, and I hope we keep making over the next few years, in a better way to help what's happening in our world today. So please give those a read if you get a chance. So let's dive into the important stuff. And for me, I think most of you who know me or have seen me lecture or been to some of these webinars know that whenever I talk about dentistry, I talk about these key things. I talk about the face, I talk about the white part, the teeth that we see. I talk about the pink part, where the teeth end, gingerly, how much gum tissue a patient may show. And then I always talk about the person and who they are and what they look like and what their personality is. So face white pink person has kind of become a standard for me whenever I'm talking about teeth or trying to educate us in what we do. And it really is such a critical part. And it's funny because as I go to labs around the country or around the world for that matter, a lot of times before I go to some bigger offices, they talk to me about what they do. And they always seem to leave out what's really happening in the office. So I'll say, as an example, are you taking pictures of all your cases? Oh, yes, we have a camera, we do this, we do that, and we have a picture of everything. And then I get there, and they have a camera from 1942, and there's one person who only operates it, but he or she's only in on Thursdays. And all of a sudden, all that spiraling of information goes down the line. And I think, Jim, you would probably know this too, right? Years ago, I took technical phone calls, and I know you probably take a billion of them today. And the hardest part when you're trying to get information from people is what they tell you and what reality is are always two different things. And that's why the photography part is so important for us, because it really is a factual representation of what we're trying to see. And without it, we're a little lost. So if you look at my friend Tracy here, you can see that She actually fell. She had an accident and she broke her front tooth. She actually knocked out a tooth, chipped it off pretty bad. But what am I looking at? Right away, I'm going to the same things. What does the face look like? Where does the white belong? And where does the pink belong? And it's our job to start putting that all together without going into too crazy detail about this case. Obviously, we visualized the patient. We did a little crown lengthening, try to improve the scenario that she presented with, and finish the case with a 3-unit zirconia framework. It was actually 2 splinted units and a single unit. So I think the 2 centrals was splinted, if I remember correctly. It was done a while ago. The point is, none of those things really matter until we see them not only in the mouth, where they're harmonizing with the pink part, the white and pink, but really where it matters the most is when we see that with the face, because the face is what really gives us the answer of what we feel comfortable with and what we don't feel comfortable with. We overanalyze the closeness of our teeth all the time, right? Most of us are looking at them either on the microscopes or blowing them up really big and trying to figure out if we got every little detail of translucency, where what I'm really looking for more these days is, does it fit with the face? Does it harmonize with the pink part? Does it harmonize with the facial features and the patient themselves? And that's really the goal to be successful for us. Challenge is when you look at the face, and I've touched on this before, our faces are not really symmetrical. We preach symmetry, and most people who come here to my office for shade consultations or shape consultations, and most of what I hear in schools being taught is this symmetry concept. And I'm going to tell you, symmetry does not exist, definitely not in nature. And in truth, what we think looks perfect if we make everything exactly the same usually tends to look very fake. Nobody's face is perfectly similar. Nobody's eyes are exactly where they belong on each side of their face. Nobody's eyebrows or cheek dominance or lip positions are just perfect straight lines and perfect matches of each other. And actually, every face has many different variables to it. You know, more square face or ovoid faces or rounder faces. And part of what we do, just like if you were picking out a set of glasses for your face, make sure we pick teeth that belong in the patient's face and not just put a mold that we think is the right mold because that's the one we use all the time. I've also mentioned a million times before that if we divide the face up and we actually look at it from a symmetrical point of view, you notice that there is really never much symmetry. A lot of people use the interpupillary line as a reference point, and I would make the argument that the interpupillary line is very seldom accurate to the horizontal representation. So sometimes it is, but very rarely. I think it's somewhere under 10% of the average person that actually has a coincidental interpupillary line with the horizontal plane. So that becomes a huge mistake, and I'll analyze that a little bit more as we go on. The other aspect that I've talked about is the face. And when we look at the face, and if you look at our patient here page and you see her face, you should be able to tell right away that on her right side, her face is larger, or what I would call more dominant than her left side. And when you look at her left side of her face, it's more narrow or less dominant than her right side. And if I break that up, you can kind of see them. And if I put those two sides together, it becomes a little bit more obvious and notice the factors in her face that make her look so different. And if we try to put perfect teeth in her face, and my argument here is when we're waxing teeth or taking a mold of teeth out of a digital environment, to just put them into the face and think that they all work because they're symmetrical when the face is not, is challenging. The example I've used for this 1,000 times is the same example. How many times do you see a denture in a patient's face and not say, that's a denture? You almost always know it's a denture. Why? Because you're taking a mold of teeth and putting it into a face that is not symmetrical. And that's where the challenge comes in. So for me, and we went through this a little bit in the last lecture, but I always talk about the transfer system. And part of our transfer system is using a Facebook or an analyzer for me, which is much better. But also a big part of that system is the photography component, being able to take a picture of the patient's face and understanding what I see in that photograph. If I look at a sagittal photograph of my patient and then I mount it, I can tell right away if this plane is accurate or not accurate. Do you think this patient's plane looks like that? No. That's obviously done from an improper face bow or an ear bow, as we would say. And I discussed this a little bit in our last occlusal lecture when I talked about, excuse me, sorry, when I talked about the importance of understanding the transfer and the envelope. So in this case, without going into too much detail, I'll just say that when we use face bows or we use ear bows, you're changing the plane or the angulation that we're mounting the cast to. When you use facial analyzers, you get a much flatter plane or a much more level plane, which is much better for us to accurately work on the patient that we're working on. And I think I've also said before that there's a million systems today that you could use that do that. So it's not like you're limited to one system anymore, which makes it better. Okay, so we take a look at Paige and how she presented, and you can see as she kind of moves and talks and acts normal, she's a fairly confident person. She actually has an implant placed in the number 8 position, and I'm really just using her to make a point here. Again, look at her face, very attractive girl. Notice the dominant and non-dominant sides. Notice the interpupillary line. Notice the eyebrows and how they're different levels. And yet, even with that missing tooth and that implant there, she still seems fairly confident and acts, comfortable, which is nice to see. So the situation is a little difficult for her. And again, I don't want to go too far into this case, except to tell you that she also had some root canals on the adjacent tooth, and the implant that was placed wasn't usable. It really probably should have been taken out, but in our case, we decided just to adjust it and put the implant to sleep. And we were going to make a bridge on it. That was based on the implant placement and position, and I was trying to manage her soft tissue, which is really kind of critical for the end result and the aesthetics of this particular case. In digital world, which everybody seems to be completely enthralled with, and I'm not against it. Again, I always say I'm very digital. We're very digital here in the lab, but I think there are some challenges that the digital gives us sometimes. We think that by putting some lines and dots and numbers to the face that it all kind of makes sense, and I would argue that's not always the case. So if you look at horizontal and you notice Paige's interpupillary line, you should notice right away that there is a difference of about 1 degree. Now that 1 degree doesn't sound like very much, and it's probably not that important, but is it? Maybe it could be. So I'm going to go through the whole process. I didn't change the Paige's facial head position. I left it where it was. I'm working at that minus 1 degree, which is where her eyes is. So her eye interpupillary line is not my reference. We're going to decide where I want the tissue to be, what the shapes of the teeth should be, and all the details that we like to do. Jen did this wax up a while ago. I'm sure if she saw it now, she's like, oh, I don't know if I like this wax up, because we all hate everything we do after we see it years later. We also tried to shorten the laterals a little bit, so you can see the laterals are sticking out a little from our wax up, and we use our tray system, our 2-part PVS and hard tray system to do the wax up transfer into Paige's mouth. That'll get placed in the Paige's mouth with our system, and the doctor's going to take a little bit of pink composite to evaluate the position of what tissue we may or may not need as we're working through the case. And he'll black magic marker any areas that stick out past my wax up for the proper length, if we agree with that. I think we actually changed our mind a little bit after we saw it in the patient's mouth. This was kind of a while ago. But the point is, we went through all the steps. So we had a diagnostic evaluation, the wax up, and then the provisional placement into Paige's mouth. And now the goal is to see that in what we call the aesthetic evaluation. What does that look like in Paige's mouth, and how does she feel? And here's what's interesting, is just to watch Paige's reaction, because this is obviously Paige before talking, and then watch what happens just putting the aesthetic evaluation in her mouth. She becomes very emotional and very attached to just seeing a tooth back in her mouth, and that crying excitement rather than the nervousness of feeling uncomfortable watching what she looks like when she speaks. So it's an interesting process, and that little aesthetic evaluation gives us the idea to understand where we want to go and what we want to do. And I hope you notice that in this photograph in the middle here, that everything is fairly coincidental to where we want it to be. The midline lines up somewhat in the middle of her face. The incisal plane is properly correct. And all that is done based on us following the horizontal reference and nothing else. But what we also wanted to prove, and this is actually a lecture, part of a lecture that I did in the AACD a few years ago, I also wanted to prove that what if we just went to a digital world and did exactly what the digital world tells us to do sometimes, and that's follow the interpupillary line. What if we did that? What if I take Paige's face and I actually take it and tilt it that 1 millimeter or that 1 degree that would make it actually horizontal reference even to the pupillary line. And then I redo everything. And then I redo the wax up, I redo all the evaluations, I send the doctor a whole different set, and we start this all over again. And now we're going to put this back in Page's mouth, and I want you to notice the difference in what happens with that one little degree of change that we made. Look at Page's incisal plane now. Notice how it's dropping on one side in the face. Notice how the midline is now canted away from her non-dominant side and going against the grain of her midline on her nose, which actually cants to her left. And that little degree, even though she doesn't seem to feel it as much and she's speaking, look at the difference in her reaction. Look at how the teeth look a little funny in her face as she speaks, all because we missed one little spot, one little degree. And this is why it's so important for us to really have an understanding of how to use the photography and understand how to make it work properly. To go forward with this case, we actually went back to the original plan, the original wax up. We took some pink shades and we did everything that we normally would do. Because we were documenting this case, and I'm not mistaken, I think, Jim, you may have a whole video on this case that you guys actually shot when we did this. So that would be kind of cool to release that one day. But anyway, I actually made two different frameworks. I made a metal ceramic framework. We're going to do a 3-unit bridge and 2 veneers was the plan here. We probably were going to need some pink ceramic, so we were kind of wary of that, although we were hoping to get away with maybe not having pink, depending on if our tissue graft took. We did make a metal ceramic frame and a zirconia ceramic frame, and I actually built them both up, and we tried them both in, and I hope you can't really notice much of a difference between which one is metal and which one is zirconia, although you probably can. The metal ceramic is on the right of your screen, where the zirconia ceramic is on the left of your screen. And then in the end, we're going to finish this up. I did wind up putting a little bit of pink on her case because I did want to have some papilla that showed that we couldn't develop back in the tissue grafting. And I did use the ceramic zirconia frame. I had no problem using the metal ceramic frame, by the way. I really believe I can make a metal ceramic frame look just as good as a zirconia frame, maybe better in some scenarios, maybe not as good in others. There's no flat rule that it's always this or always that. It really depends on the case, the environment, and what we're working with as our prep shades and our information. So we finish up Paige, and there she is, and we're still actually trying to get her back, I think 3 years later, for some finals. She actually had some tissue management we had to work on. She actually got some excess tissue that kind of grew down over the number 8 site that we had to go back and adjust the bones a little bit more and cut the bone a little bit more and bring that tissue back up. So we've been kind of chasing her to get her back in for some final. So that's where one part of the photography becomes really critical for me, is actually using it to see the face and the transfer system and make sure that we're working through the process to the best of our ability. The actual camera part itself is a little less complicated, but also just as important. For one, owning the right cameras are important today. I know there's a lot of newer cameras coming out on the market, the mirrorless cameras, which I'm becoming a fan of, although I'm not using them as much here in the office yet, although I will be, I think, soon. But really understanding how to use your cameras and which ones work for us and why. So let me give you a very quick overview of some of the basics of equipment. And let me be clear, because this is the question I get almost all the time. What's the best camera for dental photography? And I'm going to tell you there's a lot of them out there, and there's some coming down the pike that are probably going to be even better as far as with these mirrorless cameras, and which are much lighter in weight or amazing in megapixels. They just have a little issue with lighting and lenses at this moment, but that's going to be fixed. And in the next year or two, I think we're going to see some great results. So I can't tell you which one is the best. I can tell you which one is not the best. And that's this one. This is the one that it seems to me everybody thinks they could buy an iPhone and put a flash on it or do something, and they have everything they need. No, the iPhone is a fabulous camera. It's really wonderful, and the videos are even better. But what it's really good for is this, what you use it for 90% of the time, taking pictures of the food that you're eating and showing your friends and posting it on Instagram and all the silly things we do with pictures and cameras today. Have fun with that. It is not for dental photography, or at least not for color. And I want to be careful in how I phrase that. Can I use a digital iPhone or a digital cell phone to take a facial picture for references of plane? Yes. And if you're setting denture teeth and you don't need color matches and you don't need real detail, probably better than not having a great camera system. Can I use it for video today? Yes, the video cameras of the video on these phones are fabulous. And I have a whole lighting 4K camera setup that I have not used in 4 years. Why? Because now I can grab my iPhone and film that video and get just as good of quality. So I don't need to spend money there. But it is not a color coded dental camera. For that, you need full body cameras. And again, like I said, the mirrorless cameras and the normal DSLRs cameras are really the ones that we work with today. And I want to be a little clear about some of these aspects with the cameras so we're all on the same page with that. The mirrorless are coming. They're getting better and better. They are here already. The truth of it is, like I said, there were just some difficulties with some of the lenses and some of the flashing systems. But I'm going to stick to the DSLRs right now because those are the ones that are most commonly used. And the only real difference that I used to teach with camera bodies about which one to buy was basically what we call a half frame or a full frame. What that meant is the half frame bodies are a lot more cost effective. You can get a great body for $400, $500, $600, and they're really useful and you can do a lot of great things with them as compared to a full body camera. And what the difference is size. So if you notice what happens when I have a half size, you'll notice that it's a much smaller area for me to put all my photographic information on as compared to a full, and the full actually gives me more information to put it on. Now, if this question came to me 4 years ago, I would say you're fine with half bodies or you're fine with the smaller and the cheaper body. They really work great. Today, not so much. I'm only shooting with full frames. I think the full frames are much more cost effective than they ever been. And there seems to be no real difference in saving a few $100s or $200 today and not going full frame cameras. So I've switched my opinion on that over the years, and I really would rather see you shooting with full frame cameras. They capture much more information and they have a much more larger surface of pixelization for us to keep that information on. So the full bodies, or the full frame, I should say, are much better, useful tools for us. The next part of this is the lenses. And there's a billion lenses out there. Not many lenses with the mirrorless cameras. And again, those are the newer ones that are coming to market. So I'm not pushing us to go into that ballpark yet. I would say we're a year or two away from really having everything we need in the mirrorless, but eventually I will be there. I can promise you that. And I think eventually most of us will push in that direction. For me, I always try to simplify everything. And to simplify it, I want you to understand the difference in the two types of lenses that are out there. You have fixed lenses, and what that really means is the size and the weight of the lens is permanent. You can't really change that. You can rotate the lens and zoom in or out, but the lens doesn't change in size. It actually stays the same way all the time. And then you have adjustable lenses. And these are kind of more zoomy lenses where as you move the lens gets longer or shorter. Now, years ago, change is good. I would have told everybody to stick to the fixed lenses because they were better for macro photography. And I really felt like it controlled what we were doing. Today, I've switched to more of the adjustable lenses. Part of that was an influence from a friend of mine from Romania, but also part of that was really just because I saw a lot more uses out of having one good lens than having to switch lens or use different cameras over the years. So for me, I'm a fan of this lens, the Takina 100. This is actually the older version. There's a newer version that they came out with last year. And I'll be honest with you, I just bought 4 new ones and put them on my camera. So I think I try to always stay on top of what's best or what's most useful. And they're not huge investment. You're talking $300, $400 for these lenses. So not bad, especially compared to the other lenses, the fixed lenses, which are a lot more money. As far as camera settings go, 100%, I only work in manual. I never use autofocus or any of the priority settings. I'm always working in manual. And the real reason for that is because the minute you go out of manual, the camera internally is always trying to adjust for something. It's kind of the nature of the camera. Once I'm set on a priority setting or an aperture setting, the internal components of the camera are reworking themselves every time you focus on a photograph or a person. I want to cut that out of the mix, and because of that, I only work on manual. The speed that I have my camera setting on is 125, and my f-stop is always f32 or higher, and I'll explain those two things to you. So let's start with the f-stop or the aperture. What does the aperture actually mean? Well, the lower the number is, the wider opening that I have in the camera. So what that actually means is the little circle that is inside that camera lens, the lower the f-stop, 10, 12, 18, 20, the more opening I have. Now that you would think that's kind of good, but in truth, it's not, because the more opening I have, it does two bad things for me. One, it allows more light from around the area or the outside to come into the camera, which I don't want to happen. I want to control the light. And it also doesn't give me depth of field, meaning that if I'm focusing on these two centrals at a lower f-stop, notice as I start getting past the lateral, all this starts getting a little bit blurry. I'm losing that depth of field. Yet if I take it with a higher f-stop, you'll notice the picture is a little darker, but we can worry about that secondary. But notice the sharpness on the centrals, laterals, cuspids, and back. And you're going to notice that all the teeth have the same sharpness to them. So there is a difference between an f20 and an f32. And what's the difference in the opening? Here's what I have in an f20 or maybe an f whatever. And when I get down to my f32 or higher, I'm controlling that little aperture setting and focusing much more directly on the surface that I'm shooting. So I would tell you, for me personally, f32 or higher all the time, and I'll adjust the lighting in my camera to compensate that. I also mentioned to you the speed. The speed that I work in is usually about 125 to 200 at the max. What does that mean? That means when you click on the camera and you hear the shutter go up and down, it makes that little shoot sound. What that really is doing is it's closing the little opening in the f-stop that something is covering it, so it doesn't allow too much light into it. The longer that that shutter stays open, the more opportunity that outside light come in. You don't need to have that shutter open, especially since you're sitting a person that's basically standing still or sitting still for you. They're not an athlete running. So I don't need my shutter speed to be so fast that I have to capture an instantaneous. At the same time, I don't want it to be so slow that I'm allowing more light and more opportunity for me to move my hands or make the picture look a little blurry, because the shutter's open so long and any little movement I have will affect that. So my shutter speed is predominantly 125 to 200, never more than that. And then the last two things inside the camera that you need to be aware of is what they call the ISO sensitivity and the white balance. These get a little deep, and I don't want to go too deep into these. I'm just going to tell you a simplicity way to look at this. If you're using Nikon or Canon, which are the two major cameras out there today that we predominantly use in dentistry, I'm going to tell you that your ISO sensitivity in your camera should be set to 100 in Nikon and 200 in Canon. Those are the numbers. Just put those into your settings in your camera. It'll be easy for you. And very similar with your white balance, whether you're using Nikon or Canon. I like to set my white balance to the cloudy mode, which means it kind of shoots, it sets the camera up to be set in a darker environment, which is what I'm going to be using. I'm not using house lights or anything fancy. I'm only using the camera and the little lights on the side of my camera to give me all the lighting that I need. So shutter speed, let's go back and review to be quick. F-stop, 32 or higher for any of your close-up pictures. Shutter speed, 125 to 200, no more than those numbers. ISO sensitivity, 100 to 200, depending on which camera you're using, and your white balance, set it to cloudy. And those are basic, very simple settings for your camera that will make your camera shoot and function much better, as long as it's a quality camera. If it's in a very old camera and it has very low megapixels, you may not even have some of those settings in the camera. But any camera today of merit that you bought in the last 3-4 years should have all those things in there. Why is the white balance important? So you'll notice that this correct white balance photograph in the center gives me what I would call the optimal color. This is technically about 5,500 Kelvin, although that could vary a little bit depending on the outside lighting and the camera that you're using. But I want you to notice that if I take the camera out of the box and I don't put all the settings in that I just told you about, what will tend to happen is this. Your Nikons, your Canons will tend to shoot in what I call a little bit warmer temperature. They tend to have a little bit more ambery hue to them, and they tend to look a little lower in value. And that's the nature of the Canon camera, where the Nikons tend to shoot a little colder or a little bluer, where this temperature actually raises up a little bit. So that's just the nature of the cameras out of the boxes when you buy them. By changing the settings that I just gave you, you're really just balancing out the lighting in the camera for dentistry. And this is why you do have to tweak your cameras a little bit to make them a little bit more useful for you. Okay, let's go into the flash part of this. That's the basic body. Now we'll talk about the actual flashes. This is something that I've battled for a lot of years. Most of the doctors today have these little things called ring flashes. And ring flash to me is not have anything to do with how many lights are on the flash. It has to do with what's holding it on the camera. So anytime you're attaching something to your ring, it means it is a ring flash. So yes, there are 2 lights here, but those 2 lights don't matter. Why? Because the proximity of the light to the lens. Anytime you attach it to the lens, it is a ring flash. Even these, where I have 2 flashes on the side, look what they're attached to. They're attached to the lens. That makes them a ring flash. To get this away from a ring flash, I need a secondary component or a bracket. And the point of that bracket is to do what? Is to bring my flashes away from the lens. I want the distance of my flash to be a few inches, and I'm saying roughly a few inches, because it will depend on a few things, but a few inches away from your lens itself. What I'm really trying to create is this, a 45-degree angle into the patient's mouth. That's where I'm going to get the optimal colorization from my photography. And I have the ability to adjust those flashes for more power or less power separately from what's happening inside the camera. That's why the settings are one aspect, and then the flash settings are a second aspect to it. So again, 125, f32, but then I'm going to power up my flashes. And I may increase the output or decrease the output of my flashes to compensate for these numbers. Remember I showed you when I had an f20 compared to an f32, that the photograph appeared slightly bit darker on the f32. So how did I fix that? I just push the flash up a tiny bit and get a little more brightness out of the flash. But I'm getting a more accurate photograph, and I'm just brightening up with my flashes. So that's why the flashes are so critical for us. Okay, another pet peeve, or what I would say is kind of a challenge and mistake that I see with a lot of the dentistry today, is this, and that's trying to take photographs of the patients while they're sitting in dental chairs. Do not do that. Even if you see patients in your offices, or if you're teaching your doctors to take the photographs, the patient must be out of the dental chair. And I don't just mean sitting up in the dental chair, I mean out of the dental chair. They should be against the wall, either sitting or standing, depending on the height that you're comfortable with. The goal for you is very simple. This is my friend Sasha from Harvest Dental. The goal for you is very simple. I want the flat of the camera to be even to the flat of the lip, or the flat of the facial of the teeth. So what you see here right now is what I would say is incorrect. That angulation shooting up at the patient is wrong. What I want to do is move that camera up to be more at a level, flat plane to flat plane, or even be slightly higher in my angulation. So I'm coming down, same angle camera to the same angle of the flat plane of the facial of the teeth. And that's what's going to give us the best information. When you take your photographs with a patient in a dental chair, as I've done here, watch what's happening. Patient's laying back. I'm trying to move the camera up and get over the angle. I'm putting a shade guide underneath it for my reference point. If I take that same patient out of the chair and take the exact same photograph, look what happens when I compare the 2 photographs. The one where the patient's in the chair, look at the coloration on the number 8 as compared to what you see in the coloration here. Look at what you see from a length point of view. Doesn't this tooth appear a little stumpier, a little shorter as compared to what I see here? So just having improper information of how you're taking a photograph skews the information of what we need to start working through our colorization and our systems. And what I highly always recommend is that not only is the flat of the patient's tooth even to the flat of your shade guide, and then even to the flat of your camera. I want all those things to line up together. I'm a fan of incisal edge to incisal edge for shade taking. The eye sees better color, the eye sees color better in vertical lines, not in horizontal lines. I know I see people put the teeth next to them. That's a mistake. One, it creates a shadow, and unless you're changing the angulation of the tab and shooting from an angle, it really becomes more problematic than it's worse. Although there are some little tricks you could do with it that are helpful for you down the road. But for basic shade taking, I want incisal edge to incisal edge, all in the same plane, make it easy for ourselves. Other thing I always say is years ago, the old VITA Classic guide, which I don't really use much anymore, had a gray base to it. That gray base was supposed to be 18% gray, but it wasn't because it was made in 1940. You'll notice with the newer linear guides, they actually come in a gray base, and that gray base actually is about 18% gray. Why is that important? 18% gray is a very relaxing color for the eye, for the retina. And the retina, like every other part of your muscle, fatigues, like every other muscle in your body, I should say, fatigues very quickly. So the retina has a lifespan of fatiguing anywhere from about 8 to 15 seconds, depending. For men, it's worse, by the way. Women have a little longer shelf span on that for the retina fatigue. Men tend to fatigue a little quicker. And the challenge with that is after you've stared at something for 8, 10, 15 seconds, your retina has lost the ability to really detect color anymore. So what's the value of 18% gray? It's the relaxer. If I actually stare at this shade tab in the patient's mouth and then I drop my eyes down to the base, that 18% gray kind of neutralizes the eye and starts the process over again for you to be able to see color better. So it's a really useful tool that I think wasn't taught very well over the years. You heard me mention the linear guide. This is kind of interesting because it's funny, I'm not a fan of this 3D guide. I know a lot of people have these. I'm really a fan of the linear system. Why? Because the linear system actually is a little bit more systematic for me. It's much easier to teach and it's much easier to understand. I think when your doctors go from a classic guide to a 3D guide and they see this, all they see is confusion. And I get why. So I really don't recommend that this is the one we use. I recommend that we use this and all our doctors use. All my doctors today work from the linear 3D guide, and to me, it's one of the better systems. I'll explain to you how it works and why. When I'm looking to understand color and value with my shade guides, I'm looking for 3 things. I'm looking for the chroma in the cervical, the value in the middle third, and whatever is happening in the incisal edge, which is usually specific to that patient. Younger patients or older patients have different effects that are happening in the incisal edges. So I'm really looking to transfer that information. What am I looking for? What is the chroma that I want to be able to transfer? How much value does the tooth have? And how much translucency is there in the tooth? And those are the 3 things that I really want to transfer. Excuse me, why the linear system is so good, because it kind of does all those things for you very quickly. When I use a base guide, which is what you see here, the base guide is set up very simply. This is an OM2, a 1M2, 2M2, 3M2, 4M2, and 5M2. And yes, I have a little gray cutter on it that I don't even use anymore. That was from years ago when I used to calibrate the photographs more and more. But the beauty of that is what this is giving you is a middle range of the value of the patient's tooth. So for example, if I put this next to the patient's tooth and I feel like they're in the 1 range, the 2 range, or the O range, I now have a value base, I'm gonna go back 1 picture, for what I think is the most appropriate shade that I can use. That's really simple. I get that information right away in my first tray or my value tray. If I picked 1M2 as my base, well, then all I need to do is go to my 1M2 guide. And in the 1M2 guide, you'll notice that their bleaching guides are here, but they also have 1M1 and 1M2. What would I be looking for? Is the coloration now brighter than the 1M2, or is there more chroma? Bright is a bad word, I shouldn't use that. Is there more chroma than in the 1M2, or is there less chroma? So let's jump here. Let's pretend that I picked the three shade. Let's make it 3M1 was the base shade that I felt. I jumped down to my 3, and now all I'm looking for is there more chroma or less chroma? And the difference for that is L and R. If I go into the 3 Ls, I'm talking about light, and what light really means is more yellow or more opacity inside the shade tab or inside that patient's tooth. So what I'm really looking for is it more opacified or just a little bit more of a brighter looking tooth? When I go to the R range, that means there's more red influence inside the tooth or lower in value. So again, if I pick my 3M2 as the reference point, I go straight down to my 3M guide. And now I'm saying, okay, I know the values in 3M2 world. Is it brighter or darker as far as the chroma goes? Do I need more chroma or less chroma? Brighter and darker is the wrong term. I don't know why I keep using them. Once I get into the chroma, I'm really talking about the amount of color or the lack of color. And that's really the difference between value and translucencies, or the amount of light that's being absorbed into it. So a simple way for you to think of it is, anytime I pick an L, that means it's more opacified or brighter. And anytime I pick an R, it means it's less opacified, more red influence. So now you understand, I hope, why I'm using this guide. Step 1, step 2, life is much simpler and much more easy to communicate the information I'm looking for from the doctor. The other thing I do is I do use some tools. So I am using an easy shade here. I want to be honest about how I use the easy shade. So I think the important part is, does the easy shade give me color information? It does. But I tend to use it a little bit differently. I use it at the end. And what I mean by that is, my patient sits down, I take out my first shade guide, I understand what value I am, then I take my second shade guide, I understand the chroma saturation, and once I've come up with what my formula is, I think it's 1M2. Okay, that's when I actually go to the easy shade, and then I take my easy shade photograph. The easy shade is really nothing more than a densitometer. It's measuring color and photospectrometer, where it's actually measuring color in depth. So it gives me a rough idea of what the base color is in my system. And what I find is, if that coincides with what I just picked, I feel kind of comfortable and happy. If it doesn't, then I start to worry that maybe I didn't see things the right way. Oh, my remote control's not working here, why? So that is the basic scenario. I'm gonna try, I think my remote died on me, so I'm gonna have to bend forward here, okay. Well, maybe it's not remote, looks like my program's freezing up, so give it a second, hopefully. I'm getting a frozen program, let's see. I'm with you guys, I'm just wanting to make sure that my program looks like it's freezing up a little bit, so let me see why.
Yeah, this would be the section that we would kind of take out of the video.
This is the skinny part, huh?
Yeah, this is where we skinny it down.
This is,
no problem, it happens.
It's so funny, last night as I was organizing my lecture, I was saying it's time for a new laptop because this one is so full. So I guess today's the day I'm buying that, right?
On a full tank.
Sorry guys, bear with me a second. Hopefully this will. Jim, I may have to sign out and pop back in.
Okay. And
All
I'll
right.
just kind of get ahead with the backside of my stuff. So as soon as you come back on, I'll know. So
Okay.
do what you have to do.
Pop back in. I'll be right back.
I know your camera's still streaming. It's just the computer. All right. So while Peter is coming back in, let me just go over a few things here, kind of speed it up. So normally we would talk about this towards the end. We're getting close to it while Peter fixes that. We will talk about CE. Those of you that are looking for CE, we will send you an email to the registration of that you use to get on the webinar, and then we can go from there as far as getting you CE. The workshop has been recorded. It will be recorded, as I mentioned. We're kind of going to skinny it down, remove all the extraneous material that doesn't work, and that'll be done in about a day, 2 days. And then once that's ready, we'll post it on our website, VITA North America YouTube channel. So please join us there. You can also get other information as far as additional programs, additional webinars that we have as well. Visit our social media. If you need support from any of the local reps, please, contact us, whether the help desk, myself, Paul, or your local representative. This is the help desk support information right here. And then visit us again for another webinar. We're not done with this one yet. As soon as Peter gets back on, we will go from there. But visit us on the website. We have plenty of webinars throughout this year. We're also doing some remote 3-day hands-on workshops. So Peter is going to do a 3-part series. There are 3 different days, 2 hours each day. So there's plenty of time to join us, get away from your work. We will send you a set of a model. It'll be a single arch. And then with Peter's help, we're going to determine what kind of crown or framework. And then we will have Peter go step by step and go through his porcelain building technique and so forth. So please join us for that. And Peter is on the line here. All right. You're unmuted. Okay. All right, so I got Peter trying to get him back on. We'll make him the presenter, and we'll go from there. He is, it indicates he's still offline. So Peter, if you can hear me as far as the webinar goes, you're still offline. So, but anyway, for those of you that are joining us, waiting for Peter to get back on, join us for one of these webinars, especially sign up for one of those 3-day workshops. There is a fee to it because we do send you some porcelain, we send you the model work and so forth, and then it's step by step. So please join us, and I will try to now connect back with Peter to see if we can get him back in there. So Peter, if you can hear me, you're still showing it that you're still offline. So you're going to have to probably go out of the webinar and then back into it. And then I'll bring you back over as far as the panelists and the presenter goes. So let me see if you're on there again. So here we are, Peter, make panelists. All right, Peter, are you there now?
Jim, you there?
All right. Yep. All right.
Great.
So I'm going to bring you back, make you the presenter on this one. I see you in your camera.
Great. Thank you.
And then
Sorry about that.
You should be the presenter now. So
Got it. You got my screen?
yep, your screen is
Great.
back.
Thank you. Sorry about that. I'm not sure what happened, but considering how many we've done, it doesn't happen often. So I guess every once in a blue moon it happens.
Yeah, this is good.
I feel like it's me, because my program, it seems like weirdly spinning, and so I think it's something with my computer. So, okay, I'm gonna try to go forward and try to go quickly. So, basic photograph, let's kind of get into that and make sure we're on the same page with that. I want you to notice that in my photographs here, I'm basically shooting all my photographs the same way. I'm using the same lighting setup across the board. The only time I vary this, and I don't want to confuse anybody, but the only time that I don't use these two little side flashes is if I'm taking a full face shot. And honestly, what I do for that is almost nothing. I shut these two flashes off and I just use the flash on the camera, and I change my my setting to priority or portrait. And I only do that because it just gives me a little bit better light to get a full face shot. But that's the only time I make a change on the camera. Every other shot you see, dental, facial, and dental, I'm taking with my two side flashes all the time, okay? Let's see if I can move this now. Okay, another thing is I told you I want the patients to be against the wall or sitting. And a great little trick that I'll just throw out at you is if you have patients who move around a lot or squirm, just put a glove box behind their head and have them hold it against the wall. This way you can consistently get the same photos over and over again. My photo series is this, and if you guys want to take a picture of the screen, that's probably the easiest thing you could do. I'm going fast because I don't want my program to back out on me again. My headshots are basically full smile, open mouth, what we call a Duchenne smile. This is when we make the patient smile as big as they can and the eyes almost close a little bit. Full retracted photograph, full face, left profile, right profile, you could take both. And then something we call the midnight shot. And what the midnight shot is basically is a Duchenne smile, the biggest smile the patient can make. And then I make them tilt their head down. What's the point of this smile? Not to make them look evil. The point is so I could see the incisal edge position to the vermilion border or the lower lip line. And these are all just taken with basic camera settings on them. Then I come back and I'm going to shoot everything else, dental, facial, and dental, with my flashes on. And that's going to be my repose photograph, my close-up photograph, lips and teeth, left and right lateral shots where my focus is primarily on the lateral tooth. And then I come back and retract, and my retracted close, left, right, occlusals, and black background. And that is my standard sequence of photographs for basic diagnostic information. I would also tell you that part of the beauty of having these flashes movable is if you want to take surgical shots, meaning that you want to take real close-ups, or you want to light the back of the mouth more, or you want to be able to take a real close-up of something, putting these flashes together is simple because the bracket is movable. But in general, when I'm capturing hue, value, and chroma, I want to make sure that I'm using my flashes at a 45-degree angle into the patient's mouth. I just really want to control the light. The more the light is centered or closer to the ring, the more brightness I get and the less color I lose, or the more color I lose. The more the angle changes, or the deeper the angle changes in the light, the more of the better coloration that I'm getting. Another great example is this. I do get some doctors who complain and say, you know, I don't get light in the back of the mouth. And I say, well, I understand that. That's because it depends on how well you retract them and how your angle, how close you are. But I want you to compare the difference between these two photographs. This is the same patient. And because I've moved my flashes in, or I made them ring flashes, look at how much light I have back on this second molar. And if your goal here was to shoot the second molar, go ahead, move your flashes in. But if your goal is color communication, there is no comparison between the two of those. Look at the difference in what you see to the left of the screen, to the right of the screen. We need the one that's on the left of the screen. So again, anytime you're talking about color, surface topography, value, I want those flashes towards the outside. Basically, I want this effect to happen, not this effect to happen, where the light is coming too much from one source. This also plays a role when we're really trying to capture the highlights of the tooth. Look at the difference here. When the light is shot from a distance, you see where I see the light beaming up and down the line angles. I see the value and the translucencies and all the beauty of this tooth. Where here, what happens? The light is focused on the center of the tooth. I get too much reflection and I lose the ability to see inside the tooth. Also, if you're a laboratory or a clinical environment, the right tools are important. I tell you to stay away from these plastic lip retractors. They look terrible in this hygienic world today, especially after what we've all been through. They don't seem like they're the most sterile instruments that we could have, so I avoid them. I'd rather you shoot with metal retractors. The beauty of the metal is they stay cleaner, they're easy to clean, they're easy to maintenance, and they don't discolor and change the coloration of the photography as you're working your way through. And also owning a black background is important for you, or a gray background if you want, to black out or mask some of the things behind it so you can get some better shots. I also use Polarize, which I'm a big fan of. And the Polarize is basically a filter that goes on your camera and all over your flashes. And what the Polarize does is it actually flattens the surface of the tooth and allows you to see a little bit more depth inside the tooth. So if you're looking at a non-polarized photograph, although these shade guides give us some good information, look what happens when I shoot this polarized. I can actually see where the opacity is. I can tell that these white calcifications are floating over the top of the teeth. I can see how much translucency it is and look how low it goes. So it really gives me a more helpful building tool as I'm building my ceramic. I also mentioned to you that I'm using the Easy Shade. I tend to use it more for checking myself, but in the clinical environment, a lot of my doctors are using it as kind of a final shade taker, and I'm okay with that. I value the accuracy of the Easy Shade. I think anything that we have that adds to what we're doing, I want to use. So the Easy Shade is one of those things. I'm also working with something called OptiShade right now, which is a newer environment that came out, a newer tool that I should say came out. It's a little complicated to use, but the value of it is pretty cool. I won't pretend that I'm perfect with it yet because we're really just starting to get rolling with it more and more. It's basically another little camera device that you buy, and it can attach to your iPhone or an iPad. And basically, it takes a polarized photograph of the tooth that you're working on. The real beauty of it is, though, is that it has some softwares that I can actually utilize after I calibrate it and take the photograph. It actually gives me some LAB numbers, and those LAB numbers I could put into another program that comes with the OptiShade, or you have to buy it with the OptiShade, and those that software will break down some formulations for you of what ceramics you should be using, or what colors or opacities you need. So it's kind of like a scientific formulation of space, which is pretty cool. It's a little involved, and again, I'm not perfect with it yet, but I'm working with it more and more, and I definitely see the value of this process, and something that I think I'll be working more and more with as the months go on. Also, when I see my patients, a lot of them come with photos of patients they like, and I always try to tell them, okay, this is great, and I'm glad you like these, but I also show them when you really look closely at patients' teeth, they're not always exactly what you think they are, and that works both for the men and women that we see. I try to explain to my patients the importance of understanding the basics of hue, value, and chroma, and that's hard for patients to understand, but if you break it down for them a little bit and just explain to them that the color here is not the same as the color here, the translucency here is not the same as here. And if you want the tooth to look normal or real, you want to incorporate these details. If you're looking for it to look white and fake, okay, just tell me that now. But if you want them to look more real, then you need to incorporate some more warmth and some more value and some more translucencies and embrasure spaces into the teeth that you're working with. Also, sometimes teeth are angled or worn or have different typography, and I try to show them a lot of those things and spend a little time with them. To be honest with you, if during the middle of me showing them, I see that glass-eyed look in their face and they look like they don't care, I kind of get the idea that they don't really care about this. They just want them white. And if that's what they want, then we have to decide if that's what we want to do. Maybe they're not for us or we're not for them. But if that's what you want to do too, that's fine. Just be aware of the environment you're working with. It goes back to the face, white, pink, and person. Know who they are and what they're really looking for to make life easier for you. Also, I have no problem telling the patients that sometimes the gingival architecture is part of their problem, meaning that if I'm making a tooth here on the number 9, what's the odds of me making this match the 8? The odds are slim. Why? Not because I can't get that color pretty close, because no matter how close I get it, it will never look the same because of the size. The larger tooth always appears brighter, where the shorter, dumpier tooth will always appear darker and warmer. The only way to fix that would be gingival graft or crown lengthening. Which one is better for the patient? That's up to them. Although obviously the crown lengthening will be the simple procedure and give us more space to work the restoration in. So all these little communication tools are really important for you. Also, when we're building our teeth, I also like to say that each tooth has its own representation. For me, the centrals with their chroma value and translucency really show you the age of the patient that we're trying to achieve. The more embrasure spaces I put in, the younger the teeth tend to look. The less embrasure space, the older the teeth tend to look. But that doesn't mean that some people need less embrasure space just based on their facial feature. When I get to the laterals to me are very gender oriented. The squarelateral works very well in both male and females, but the rounder lateral tends to work better in females. Doesn't really work as well in a male face. So I think when I look at laterals, you can have a square or straighter lateral in both men and women. But if I'm going for women to have a rounder look, I'd rather have a rounder lateral, although I have no problem with the sharper square lateral either in a woman's face. It actually looks quite good. And then lastly would be your cuspids. And those are kind of more about the personality, right? The sharper point, the more embrasure space, depends. It gives you kind of an aggressive look or a softer look, depending on how you roll that and how you create that space and shape. So I'm trying to think through all of those processes as I'm working my way through shade incorporation. And sometimes when I'm working through my shades, it's a lot more simpler than all the things I just told you. Our only job in a case like this is to do what? To make that match. I don't see gingiva, but papilla looks pretty good. All the rest of the teeth are what they are. So really all I have to do is try to match what I see in nature. Could this patient use a little crown lengthening? Maybe. Really, they probably need a graft here, right? To close this off and protect the tooth. But the patient doesn't show that, so it's not as much of an issue for us. I want to take all the standard photos that I told you about. Notice I have 2 guides for reference. I can also shoot that in black and white if I wanted to, or in polarized, which is very important for me. And you'll notice the polarized again gives me that little bit of opacity and the amount of translucency that I can see. We're going to treat this as a veneer restoration, so it'll be very minimally invasive. And the prep shade is fairly good, right? You can actually see the coloration on the prep already. The value is not bad. I just have to really incorporate the translucencies and the colors that are there. So we provisionalize the patient, send the patient home, and I'll go back and fabricate my final restoration. I fabricated this with VM9 a few years back. Here it is on the try-in. I'd say the value looks a little on the lower side to me at this moment. I think the patient was fairly happy with it, and we just let it go at that point. Could I have improved it? 100%. I always feel like you can, but the goal is that if the patient's happy and we're really close, how much we overanalyze goes back to that face white pink concept. really what I care about is that I get the basics right. And what are the basics? Look at my polarized photographs. The value could have been up a hair over here. And by the way, had I taken this in the OptiShade, it might have showed me that my numbers were off, because I can actually scan my restoration and compare the two, which is why I'm kind of liking the concept of the OptiShade. I could also do that with my Easy Shade. I could shoot the tooth and come up with my numbers and then shoot my restoration on a similar background and evaluate if I'm in the same ballpark. So I'm just trying to use all those tools to really make it useful for me to do the best I can and have the most amount of information I can. And in the end, it all comes back to what we said. What does the face look like? Where does the white belong? Where does the pink belong? And how do we make that all work together? So I'm using my photography to make sure that I have the right plane in the patient's face, the right horizontal plane. And I can check that with the mounting table that we've used to transfer. We're doing our diagnostic wax up based on that information, horizontal reference, not the interpupillary line. We're taking all our prep shades like we normally would do. We did some crown lengthening. Our wax up becomes our provisionalization. And we can see that the alignment of the teeth look pretty good. It's pretty much what we wanted. So we're feeling confident about that. We're checking all the shades again to make sure the direction that we want to go. And then I'm going to come back and actually finish up the restorations. And these are, again, were VM9 veneers. This is kind of a few-year-old case too. Final restorations on insert, and tissue looks like it's still healing up a little bit, but I think you get the idea. So that finishes us up. I think, Jim, I'm still somewhat on time, despite our little hiccup there. And I definitely feel like it's my computer, not yours, because I feel like my program, I can see it spinning and bogging down a little bit. So I think I better get a new computer before I start traveling next week. But with that said, I think we're about on time. Let's see.
Yeah, no, you're doing well. So thank you, Peter. Appreciate it. I'm going to take this away from you real quick, and I will quickly show.
Sorry about that hiccup there, Jim. And I think it's me freezing up, to be honest with you. I feel like my computer's running slow.
Oh, that's no problem at all. It works out at the end. Great presentation, a lot of good information. I learned quite a bit myself. We are at the point where we can pick up some of the questions and so forth, but just a reminder, I went through this with the audience before. Your CE would be through the email from the education department that we will send to you. If you don't get it in a few days, go ahead and give us a call. Everything is posted. Today's webinar will be posted on our VITA North America YouTube channel in about 2 or 3 days. You can get a hold of Peter. Here is his contact information. And while we are there, let's look at some of the questions. So, does ambient lighting and ambient temperature play a role in good quality intraoral photography? And if so, what are your suggestions to counter environmental?
Yes, and taking ambient is really bad for you, so don't do that before you take your shades. Yes, the ambient lighting is actually not what we want. We want all the lighting to be controlled from the camera. That's why the settings that I'm telling you, the manual settings, the speed and the shutter speed and the opening and the ISO and the white balance is all internal camera settings. And then setting my flashes up to control the lighting is what I want. I don't want to have any interference from the room lighting, the outside lighting. I want to be able to turn my camera on and shoot a patient if the room is the brightest room ever or the darkest room ever, and have it have no effect on my camera. So I'm trying to control the camera settings to make that happen.
All right. And then we have another question here. Can you further review the difference between value and chroma, and what specifically how you are using them when looking at a tooth to determine shade?
Yeah, so that's a tricky answer without me going off in a 30-minute dialogue on it. So I'm going to try to simplify it for you. First off, One of the mistakes I think we make when we take shades is actually only looking for value or only looking for chroma. In truth, when I look at a tooth, what I'm really looking at first is translucency. What kind of translucency is on that patient's tooth? And what I mean by that is, when I look at the incisal edge or down the mesial and distal walls, I can see a certain amount of translucency that either allows me to see through the tooth and see mamelons or colors or structures or what's behind it, sometimes on the incisal edge, or I can't see through the translucency, meaning that there's a whiter frosting enamel over it. And the reason that's my first determinant is because that has to make me think of how I'm going to build my restoration. So for an example, if I see that the tooth is very translucent, means it has a lot of translucent surface on it, I know, and you know as a ceramist, that your job now is to build translucency on the outside of that tooth. Problem is, the minute I build translucency on the outside of the tooth, what happens to the value on the inside? The value tends to drop. So even though that I'm taking my shade value, I might be compensating for it. What I mean by that, my 1M1 was really close in value. Okay, great. But it was a very translucent tooth. So I'm thinking that I need to finish with translucency. I might not use 1M1 inside. I might use OM3. I might use OM2. I might use something a little brighter to pick up the value because I'm going to lose some of the value with my translucency. So value is really more about not black to white. It's a silly definition that we use. Value is really about how much light can be absorbed into the tooth and how much light can be reflected from the tooth. A bleached surface reflects teeth light. That's why the teeth appear brighter and whiter. A translucent tooth absorbs light into it and it makes it appear lower in value. So I'm really thinking about translucency and controlling the value from the inside.
All right. We have another question for patients who have multiple spaces, diastemas between their teeth. Would this complicate intraoral photography due to the light-dark effect?
No, because you're focusing on a tooth. That's, again, you could use a black background if you really want to mask everything out behind it. But realistically, the shade that you're taking is usually on a tooth that's in the mouth. So if, let's say, the number 8 is missing and you want to take shades on the number 9, your focus is on the number 9, your shade tab is underneath the number 9, all your photography is focused on the facial of the number 9. So no, spaces don't bother me at all.
All right, and then we often get this question, take shades with or without a window?
Say that again?
Take a shade with or without a window next to you? The patient, should you have a window next to you? Should you not have a window? Or
again, I'm not sure, maybe I wasn't clear enough before, but let's be really clear. I want the camera to control everything. I want the camera to control the lighting, the value, the f-stop, the density, all this stuff is inside the camera setting. I don't want to use external light, and I don't want to have any effects of the light from the room or from the outside. How do I do that? By closing my f-stop. The more that f-stop is f32 or higher, the smaller the opening in, the less the area around me is a distraction. So I could take my camera, I could walk into a well-lit room and shoot that patient and get almost a perfect photograph. I could then take that patient into a closet, into an environment, completely dark space, and take the same photograph, and my photographs will look the same. I don't want the influence from the outside.
So controlled lighting, such as a color-corrected lighting, D65, D55, the D65 lighting environment, right?
Yeah,
as far as the external lights, if you're not going to use photography.
Oh, okay, so if I misunderstood the question, do I want color-coded lightings in the clinical environment? Yes, 100%. Would I use a window as a color-coded lighting? No, because I can't count on northeastern daylight savings time at 2 p.m. and 10 p.m. with the wind and the clouds the right direction. It's not countable. So yes, should you have color corrected lights in the operatory? If that was your main question, yes. But really, I'm using the photography in the camera as my lighting, not the environment.
So another question related to visual shade taking, in a sense, what paint color would you recommend for the walls?
So it's funny because I was always in the light gray family, the early 18% grays, and I was gray in here for a lot of years. If you saw the picture of my lab now, I painted it yellow, so so it's completely against the scheme of all the things that we talk about. But again, I control the color in my camera, so I'm not really so worried about the wall color as much as I used to be. I also have a very open, large space, right? So it's a little different for me. If you're in a very tiny environment, then obviously the best colors are the 18% gray and the lighter, which is really kind of the best color pigment for your eye. But I don't worry about it as much today because of the quality of the cameras.
Excellent. So this is a comment question that often people feel lost in, but it's kind of, the question itself kind of answers itself. So they see a difference between what they see in person versus the photos. Is this because the camera settings or nature of the camera photo settings?
So yes, it is, and it shouldn't be, right? It should be that what you're seeing in the camera is what you're seeing in the patient. Obviously, color coding your camera and setting all the settings that we talked about will help you with that. The real test that I really think is the hardest part is seeing your restorations intraoral and re-photographing them, because that's where the real learning curve is. And that you take that picture of the single central, you spend all your time looking at the polarized photograph and the easy shade that I use and everything that I've done, and then I build it up and I put it in the mouth and it doesn't match. I say, well, wait a second, what did I miss? Well, whatever I missed isn't as important as what I learned from what I missed, right? When I look at those two and I say, I didn't get the value right, I didn't put enough translucency in, maybe I picked the wrong substructure, that's where I have to really learn to make the adjustments on how I'm viewing what I'm seeing in the camera lens, because the camera lens is a mechanical device, it's not your eye. So you're compensating for what you see based on a reference point of a shade tab, based on the reference point of an easy shade or an opti shade, to make yourself adjust to the build-up process to make it work.
Do you use a camera light box?
I don't use any light boxes. My camera is set up the way you saw it in the photograph. I use it for 99% of everything I do, and the only time I ever put boxes on anything is when I'm taking headshots for final cases. To clarify on that, some people are asking me, if you're asking me about the light box to get a no background on a model or on teeth that you're taking, I would tell you that if you're using a high quality camera with the right setting, and I just hold the object here and my camera here and take my picture, I will get a black background here without using any sort of light box. So every photograph that you have seen is basically me holding the model and taking the picture with nothing behind it.
All right. What do you feel? You kind of went over this, but if you can elaborate a little bit more on what your feelings are about the fact that shooting above an f-stop 22 causes loss of sharpness due to the diffraction. Is there a compromise there? What's your feelings on that?
No, so it's above 32, to be honest with you, not 22. I shoot 32 and above. I never go below 32. I tend to shoot around 36, sometimes even in the 40s, but I'm pretty comfortable adjusting my light settings to do that, right? So I tell people, stick at 32, and if you take the shot and you feel like it's a little too bright, go to 36. This way, it's kind of a very simple change to make it easier for the clinician people who having their assistant take the photographs. I don't want them playing with buttons, but I never shoot below that. If I needed more light, I'm not going to drop to f22. I'm just going to give myself more light with my flashes.
All right, so this is a good question. I think that what do you do, how do you manage your photos afterwards, post, when you're starting to review them and look at them, analyze them? The question is, do you use like a Lightroom? Do you use a case management software or photography management software?
No, I'm a Mac guy, so everything goes straight into my iPhoto. And in my iPhoto is where I keep every photo that I've taken. And then I will take those photos out in groups and put them into my shared Dropbox with my doctors. I don't touch the photos. I don't clean the photos. I don't alter the photos. Most of my photos that you see are me grabbing them from iPhoto and throw them into my keynote presentation on a plane to go somewhere and work with them. I don't do any alterations. I don't clean or change or do anything. And my storage is, like I said, they all go straight to my iPhoto. From there, I will put folders of the photos into the patient's folder, which I share with my doctors in a Dropbox system.
And then do you shoot in RAW or a JPEG?
I shoot in JPEG fine 90% of the time. Right now I'm doing some AACD things and they want raw photos, which is kind of insane to me, but okay, I get it. I guess people cheat and do things they don't. So the last case I just did for a doctor in Ohio, I shot on raw, but boy, those photos are 26 megabytes every one, and it's a lot of material for a photo. So I don't do it consistently. I only do it when I'm doing it for submission.
All right, so question about white balancing. The question is really, can you explain how to do the white balancing? But I assume, if I recall, there is actually a setting for white balance within the camera.
Yeah, so there's actually two ways to do it, depending on the level of your camera. So the better cameras have what they call a white balance button. I can actually hit the button and take a picture of something that will give me an internal setting for white balance. What would I do a picture of? An 18% gray card, right? So I could have an 18% gray card, set my camera up, hold in the white balance and take a picture of it, and that will internally set my camera to an 18% gray. Do I do that? Not anymore. I did that years ago. What do I do today? I go to the white balance settings in the camera and I set it to cloudy, and then I never touch it again for the rest of that camera's life. So the simplicity of it is set it to cloudy and work around the flashes after.
All right. Well, thank you very much, Peter, for all the information, the excellent presentation as always. Any last minute comments you want to make for this subject matter?
No, I mean, it's a detailed subject. I think it's important. I apologize for the technical glitch. Those are frustrating, but in the interim, I hope everybody got the information they want. You could always email me if you have any other questions. Nobody asked, I'm shooting with the Nikon D750, which is what I use for everything. I actually have a few of those bodies left because they discontinued them. I bought the last 3 or 4 that I saw out there, so I can keep using them for a few more years until I switch over to mirrorless. I look forward to being in front of people again. So I think I'll be in Texas next week and Florida a few weeks after that. And where are we? I think we're in Colorado and a bunch of different places. So I look forward to that and look forward to seeing everybody live again and getting back to normalcy. So thank you guys for attending. You know, I think I am always overwhelmed, Jim, that we do this once a month, and every time I look and I see, you know, 150, 200 people that are still signing up, it really makes me feel good. So thank you for everybody.
Well, think about it. Some of these are 300, 400 people, so it's still going strong.
Yeah, so it's amazing to me, all the people that keep coming and supporting. So thank you guys so much. It really means a lot. I appreciate it and hope to see everybody soon. Thank you for your time with me.
Well, thank you. I appreciate it, Peter. And the audience, we greatly thank you very much for joining us today. Please join us for some future Peter Peasy webinars that we'll have throughout the year. Please visit our website and you'll get those dates and the topics. And again, Peter, thank you very much. I wish you a great day and a great remainder of the week. So you take care. This will now conclude today's webinar.